All right, folks, we're going to go ahead and return to our content here today and move into the land of medications. And to take us through that, we have our good friend, Pharmacist Chris Blem, who's worked in the Emanuel Internal Medicine Clinic since 1998, when dinosaurs ruled the earth. Where he did his initial research and pilot projects in hypertension, creating some of the very first collaborative drug therapy management protocols to help physicians get more of their patients to goal blood pressure. This was the start of their clinic of what's now recognized as a patient-centered medical home. He's continued to help develop about 10 other CDTMs for the Legacy Medical Group clinical pharmacy team to assist patients with safely and effectively utilizing medications to better their health. You're in for a treat. Please welcome Pharmacist Chris Blem. Welcome, brother.
Thanks, Paul. All right, can you guys hear me okay? I usually am pretty loud. So Dr. Rueda did a great job of talking all about hypertension, stole all the thunder for the medications. You guys probably have all learned it all now, so I don't really have a whole lot to say. Giving a talk about hypertension meds isn't really sexy. You know, I really like talking on the diabetes meds. There's lots of new meds coming out. It's really fun and what I consider sexy. But hypertension, pretty much all the drugs now are generic and cheap and affordable, and so you know, anymore, this talk is kind of routine. But we're gonna just go through the medication classes, the common ones that you guys are going to see. Hopefully you can just recognize by their names what class of drug they're in and generally how they work. We're not going to go into details about their mechanisms, but we'll talk about it briefly. And then, you know, what I do in our clinic is work with a lot of patients, not only with hypertension, but a lot of disease states on improving adherence to medications. And you guys probably are well aware of that out in the community, working with patients, and adherence is a big problem. And then actually, probably Dr. Rueda covered a lot of the other things, which was, you know, sometimes medications don't work, and so we'll talk about that as well. Big fancy chart. Point is, there's a lot of other things other than the kidney that cause high blood pressure, and all of these kind of are targeted by different medications. So, you know, when you're explaining something, why patients have to take multiple medications, you know, just saying, you know, there are a lot of mechanisms behind high blood pressure, and so just targeting one of them isn't always the answer. And then educating our patients about, you know, why we're doing this. Well, we're trying to prevent strokes, you know, retinopathy, development of heart failure over time, chronic kidney disease. So those target organs, you know, you can go from the head to the toes, talking about peripheral vascular disease. You know, all of those things are end results of poorly controlled hypertension. Kind of already touched on this, but, you know, giving patients medications, treating them to goal, we can really reduce the risk of stroke, MI, heart failure, and I think he mentioned, but, you know, each stage in hypertension, for every, you know, you can really get a reduction in cardiovascular mortality as the meds go up, as the stage of hypertension goes up. The more you treat them, the better they're going to be. You know, and pretty much most of the major classes of drugs have evidence to support them now. That wasn't always the case. So we already had this graphic up and kind of learned about it, but essentially, you know, this is in the primary care setting where we're starting, you know, and we're going to talk about kind of when to start these medications and what medications to pick. In, you know, those resistant cases and stuff, you know, those are often being shipped off to specialists to help deal with. But in the primary care setting, we're starting here. So, you know, I'm just going to go through the major drug classes, just give you a few things. The thing about ACE inhibitors, you can usually recognize them as the Pril drugs. You know, they all end in Pril. You know, this is a list of the generic names on the left and brand names. They're all generically available and affordable. I believe that we verified that all these are on formulary with CareOregon too. This is just talking about onset of action, peak effect, duration of action. You know, most of the time with ACE inhibitors, you're going to see lisinopril. I mean, it's very rare that you you see another ACE inhibitor nowadays. Sometimes some enalapril, pretty rarely captopril because you have to take it so many times during the day. So we know that that really affects adherence. So again, ACE inhibitors, big fancy slide, but ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2. So they're angiotensin converting enzyme inhibitors, ACE inhibitors. And that angiotensin 2 does all these things down below, you know, to increase blood pressure. So it's really important to block that angiotensin 2 in patients with hypertension, and ACE inhibitors are a great drug to do that. So Dr. Rueda already said, you know, we use it a lot as a first-line agent. Isn't always a first-line agent, but, you know, it's certainly within the possibility of starting it right up front. Obviously, talk about the effects on the kidney and helping with nephropathy, albuminuria. It has been shown to reduce morbidity, mortality, and stroke prevention when used with thiazides as well. The you know, side effects are certainly there. You know, dry cough, anywhere from 10 to 30% of patients, so that's a pretty broad range. In clinical practice, yeah, I'd say, you know, 20% of the folks, 2 out of 10, probably come back with a dry cough at some point in time. Really, it's that cough that won't go away. You can take cough medicine, you know, anything else, but the only thing that really makes that cough go away is removing the ACE inhibitor. So you can recognize that when you're out in clinical practice a lot. And it's a dry cough, not sputum production. And it's just kind of a nagging cough if you guys have ever seen a patient with it. It's, you know, they're doing that all day long. So always think, every time a chief complaint for cough comes into the clinic, I'm always looking at their medicine list to see if they're on an ACE inhibitor. Hyperkalemia, talked about that earlier. So monitoring labs after that. Skin rash, a little more prominent with captopril than some of the others, occasionally happens. Angioedema is more serious side effect. It certainly happens. I've seen several cases over the years. This picture is patient walking into the clinic. You know, so that's the clinic picture. Patient calls in the morning. They're like, I woke up and my lips, you know, 5 times the size of normal. They walk into the clinic. They're on an ACE inhibitor. It's very likely that that's what's going on. And the prevalence is higher in African Americans. You know, generally speaking, you know, this is the most prominent feature of angioedema that we see in clinic. But they can also have numbness, tingling in their tongue, anywhere in the oral area. There's also gut angioedema and other things, but this is the most common presentation. And then, you know, monitoring them because of the decrease in GFR is really important. If they happen to have pre-existing kind of renal artery disease, so bilateral renal artery disease, and you give them an ACE inhibitor, you're going to find out about it when their creatinine doubles, and then we'll have to change things around. And then hypotension is actually pretty common in people with fairly mild hypertension to begin with. You give them a dose of an ACE inhibitor, and usually in Caucasians, because African Americans don't respond as well to ACE inhibitors, and after the first dose, you know, they're hypotensive, they're dizzy, they're calling the doctor's office saying, what's going on? You gave me this drug. And so trying to make sure that you're educating them up front to be careful when they're first starting the medications. And then it is contraindicated in pregnancy, and again, bilateral renal artery stenosis.
Christopher, if they don't have a kidney assault, how long typically do you wait before you restart them?
If you have a kidney injury from a mild kidney injury, like, you know, their creatinine goes up a little bit. Well, you don't always necessarily, I mean, it depends on what other medications they're on as well. You may back off on the diuretic or just, you know, hold it for a few days and restart it. So there's no, you know, perfect way to do it, but, you know, generally speaking, a lot of times I think that I work in a resident clinic where our resident physicians get really excited and they're first learning how to treat high blood pressure, and their creatinine goes from 1.1 to 1.3, and they panic and, you know, stop the drug. And so there's a lot of education about, you know, just ride this out. This is going to be fine. This is an expected change in your GFR. you know, and trying to alleviate some of those worries early on. The ARBs, or the sartans, so they're the angiotensin receptor blockers. You know, these are probably more widely used in terms of within the class. You'll see a lot of losartan, but there's a lot of patients that are on valsartan and olmesartan and irbesartan. So, you know, whereas ACE inhibitors tend to be focused a lot on lisinopril, this whole class of drugs tends to get used more. And I think fortunately now we're pretty much at the point where most of these are generic and affordable. Kind of doses of these drugs. Typically, Dr. Rueda was speaking to, you know, try to get at least half of the maximal dose for most of these patients, so kind of targeting the middle of that range. And then where these ones work, again, we're blocking angiotensin 2, but we're doing that a little further. Instead of blocking this enzyme that converts this to this, we're actually binding to that receptor on angiotensin 2 and blocking it directly at that site to prevent further downstream effects. Again, they're fairly interchangeable with ACE inhibitors now. ACE inhibitors kind of have a longer history of data to support them, but ARBs have been studied now for a number of years and pretty much have replicated most of the data in terms of clinical benefits. So really, we kind of use them interchangeably, and we'll talk in a second about that. Adverse effects, really pretty similar to ACE inhibitors, although the cough is virtually non-existent. So people who have a cough on an ACE get changed to an ARB. I think maybe one suspected case of a cough in the last 20 years on an ARB, so I really don't see that it happens. Angioedema is not completely non-existent. It still will happen with an ARB, but it's much less likely. And so if somebody has a real strong indication for being on an ACE inhibitor or an ARB, you know, they have heart failure or something, and they had some mild angioedema like that picture, and they were taken off the ACE inhibitor, you could still try them on an ARB, cautioning that patient about the risks of angioedema, what happens if it does come back, precautions. There was a small study a number of years ago where patients who were on ACE inhibitors who had angioedema, actually they were then transitioned to an ARB. And I can't remember exactly, but I think it was, you know, over half of the patients, you know, no, actually all but like 5 patients in that study ended up being fine on an ARB, never had another case of angioedema when they studied it, and a few did. So, you know, I think the indication has to be strong, and then the degree of angioedema, I think, really comes into play. We had a patient who had, you know, pretty severe airway compromise with her first case of angioedema. You know, I don't think that we're going to risk that. You know, some lip swelling we'll talk about, but, you know, if they have airway compromise, we're probably going to avoid that class of medications. Dr. Rueda already spoke to this. Here's your eplerenone spelling. But these two drugs, aldosterone renin receptor antagonists, the two that we commonly use now. So those actually are over here. So he already spoke to really all of that in terms of blocking aldosterone synthesis. We're using them, as he mentioned, in resistant hypertension. You know, that's kind of the indication for them nowadays. You don't see them used for just primary hypertension, but if that patient does have resistant hypertension, those 2 or 3 meds, you know, with a diuretic in there, this is the drug of choice in those patients. You better be thinking about hyperaldosteronism, because if you have that and you can take care of it with adrenalectomy, that would be preferable in a lot of those patients. And then it's also indicated for congestive heart failure. So, you know, you will see it a lot in your patients who have congestive heart failure with an EF less than 35%. They're going to be preferably on spironolactone or eplerenone. It has pretty significant reduction in mortality in those heart failure patients. So you will frequently see it in that sense. of course, it causes the hyperkalemia, the gynecomastia that he mentioned, is possible. And those are the cases that you're generally switching over to eplerenone. And then monitoring serum creatinine, potassium, keeping an eye on that. You know, if they start off with a baseline elevated potassium, you really have to watch that, as well as if their kidney function's poor to begin with, you got to watch the doses and watch their electrolytes real carefully. So, and then all the thiazides, we mentioned chlorthalidone earlier, and hydrochlorothiazide, probably the two most common thiazides used. The loop diuretics are generally not used in hypertension purely, but often in heart failure, and the potassium-sparing diuretics as well. So thiazides, you know, mechanistically work in the kidneys at the distal convoluted tubules to excrete urinary sodium and potassium, and so as you can imagine, side effects tend to be the hypokalemia, hypomagnesemia, hypercalcemia, all the electrolytes that are being excreted. They are basically the cornerstone of most antihypertensive regimens from the first Joint National Committee, you know, guidelines. So they've been alone or in combination as first-line therapy ever since the start, whereas other medications like beta blockers have, you know, kind of went up and down over the years in terms of their use. Another thing you might think about, just keep in mind with thiazides, because of the interaction in the kidney, there is possible with lithium toxicity. So you may have patients with mental health, bipolar disorder who are on lithium, so keeping that in mind. Usually, you know, those patients are getting started on it. We're asking them back in the clinic in a week to get their blood drawn, often recheck their blood pressure at that time and monitor their electrolytes. As we mentioned earlier, the chlorthalidone is quite a bit more potent than hydrochlorothiazide, so you know, looking out for those electrolyte abnormalities with that's even more important. You know, and essentially, you can give them down to, you know, GFRs of really nothing. It's just how effective they're going to be after their creatinine is elevated. You know, if they're not making kidney or not making urine, then we're not going to be using them. Loop diuretics work in the loop of Henle, which is earlier in the diuretics action in the kidneys, and essentially, you know, their action's shorter, it's more intense. You have your patients who are really complaining about urinating all the time. With loop diuretics, it's really used in heart failure management of lower extremity edema, not really for blood pressure management for the majority of patients. Unless they do have kidney disease, sometimes we do use loops in some of those patients. Which is, I guess, what we just talked about, and that, you know, dosing them in the morning. You know, it's amazing to me over the years. I still have patients come in and, you know, for whatever reason, they're taking their diuretics in the afternoon or evening. Maybe they were told that, maybe they weren't, but, you know, and they're complaining of nocturnal, you know, polyuria, and so just moving it to the morning, simple. Again, the electrolyte abnormalities, keeping in mind it can precipitate gout. That's, you know, in your gout patients on diuretics, that's an important thing to keep in mind as well. You know, the potassium-sparing diuretics, you know, they're really there to spare potassium. They're really not there for blood pressure management, and except for, yeah. They come in combination, so Dr. Rueda's case, I think that patient was on triamterene hydrochlorothiazide, pretty common one. And so they're a nice addition to a thiazide to not have to give potassium tablets to some patients. Again, hyperkalemia, you know, you want to watch them in patients with CKD because those will increase their potassium even more in your CKD patients. So. Calcium channel blockers, again, kind of broken into two categories, dihydropyridines, non-dihydropyridines. and amlodipine being the most widely used drug. You see a few people on nifedipine and felodipine, but that's pretty much it nowadays. Non-dihydropyridines, the diltiazem and verapamil specifically, kind of usually are used in the arrhythmia settings. The dihydropyridines tend to work on the peripheral smooth muscle arterial vasodilation. So, we'll talk about side effects in a second, but that's kind of what leads to the side effects, whereas the non-dihydropyridines work on the AV node, slowing down the heart rate. So a lot of the adverse effects come from that mechanism. Dihydropyridines are really first-line therapy, as the guidelines said, as long as they're the long-acting ones. There was really concerns about short-acting calcium channel blockers being given in the emergency rooms and causing increase in mortality, so we don't really use short-acting calcium channel blockers much anymore. They're really good at lowering blood pressure. They're effective in African Americans. They can also improve anginal symptoms, so in your patients with CAD, they may actually help them as well. The kind of limiting side effects for amlodipine or the dihydropyridines is really peripheral edema. It seems to be pretty dose related, so you see that patient on 10 milligrams of amlodipine and they've got peripheral edema. A lot of times you can back them off and alleviate some of that by being on a lower dose with not a lot of difference in their blood pressure a lot of times. So that's something to keep an eye out for. That reflex tachycardia, so a lot of times the dihydropyridine calcium channel blockers like amlodipine will increase the heart rate as opposed to the others that will decrease. So verapamil and diltiazem will lower your heart rate, but amlodipine can increase it a bit. I've seen cases of flushing over the years. Patients will take them, get that peripheral vasodilation, causes a little bit of flushing. That's usually pretty self-limited. And then that dizziness and headaches is relatively common, but will go away after a few doses. So getting the patients to stick with it, using lower doses to start them on, ease them into it. Usually those non-dihydropyridines are used in arrhythmias. That's the most common place that you're going to see them in. And then, there's both short-acting and long-acting, but we really want to use the extended release products in our patients with hypertension. They do help to reduce the risk of hypertension complications. They do work. They don't have the strong evidence that a lot of the other drugs have, including amlodipine in the calcium channel blocker class. So occasionally you'll see them in headache prophylaxis. Patients with chronic migraines, they've been shown to help kind of decrease the frequency of chronic migraines. So it's another time that you might see them. Constipation, bradycardia probably being more common with these than peripheral edema. And have to watch them when you use beta blockers. You put people into heart block if you use a beta blocker and a calcium channel blocker. Not saying that you can't, but monitoring carefully if they are doing that. And obviously that's the contraindication, and we're generally not using in heart failure, the non-dihydropyridines in heart failure, because we don't want to decrease that heart rate in those patients. And then beta blockers. So Dr. Rueda kind of mentioned, atenolol falling out of favor, and I completely completely agree. Over the years, atenolol was very common. We used it a lot as the other ones were brand name, and now everything's kind of become generic, and we've got more data, and now it really favors the use of carvedilol in the majority of patients with hypertension and heart failure. So you'll see most of our heart failure hypertension patients on carvedilol or metoprolol. Metoprolol, although not quite as good evidence base for it as carvedilol, they have a generic once-a-day version. So if you have that patient that you just can't get to adhere to twice daily therapy, you can give them metoprolol ER and works. Those cardioselective beta blockers, the top ones, tend to lower the heart rate more. So you sometimes are dose limited by their bradycardia, and switching them to carvedilol, you can push the dose higher and don't drop their heart rate as much. So it's a time where you're maybe making that change. Yeah?
So if we come across a patient who's on the atenolol with controlled blood pressure, should we just try the metoprolol instead?
I'd probably try carvedilol if they can tolerate twice daily therapy. If you're really going to stick with once daily therapy, then metoprolol ER. There is a once a day version of CareOregon CR, which is carvedilol, but it's not affordable. So at this point, we're not really using it much. But you know, I think that yes, I mean, the evidence now shows that other beta blockers reduce the risk of stroke, you know, more than atenolol does. And I try to teach our residents too that atenolol still works. It's still a blood pressure lowering medicine, and it works, and it has evidence. It just doesn't have as strong of evidence. There's more reduction in cardiovascular mortality with other beta blockers. So, you know, you'll see patients come in on atenolol. If they're doing well, you know, we don't routinely switch people, but if they're not doing well, that's a good reason to definitely change things around at that time. So they're blocking the sinoatrial node, decreasing the sympathetic nervous system. So in the kidneys, they can reduce angiotensin effects, and obviously we talked about reducing heart rate and cardiac contractility. They are, at this point, kind of reserved for, in the uncomplicated hypertensive patient, really third, fourth line after probably spironolactone anymore. But it's rare that you have that patient who has that poorly controlled blood pressure that you're going to get to a beta blocker and doesn't have another indication for a beta blocker. So really common to have atrial fibrillation or a ventricular tachycardia or something in which, you know, ACE inhibitors beta blockers are being used in those other reasons. And heart failure, you know, the reduction in mortality at heart failure for these patients is pretty significant with beta blockers. So, you know, they get added into therapy. So then you're trying to figure out kind of which drug is for which comorbidity. So in terms of just pure hypertension, though, not really used much anymore. And then we talked about the bradycardia. In patients with severe bronchospastic, you know, disease like asthma, it's not that you can't use, you know, cardioselective beta blockers in those folks, but there are patients who are really responsive in those poorly controlled asthmatics, and giving them a beta blocker can actually set off that bronchospastic disease. They do tend to cause a bit of exercise intolerance and fatigue, so patients will, you know, complain of that. You know, ever since I've been on that carvedilol, I just can't do what I used to do. I'm more tired. It is a side effect and a real one, and as well as erectile dysfunction. You know, our male patients really do complain of that. So you have to take it into consideration, but you know, if they have a heart failure or something, you really want to be using these medications. So, so if they already have dysfunction in their sinoatrial or AV nodes, or that severe bronchospastic disease, you probably should avoid beta blockers for the most part. So just kind of some management pearls, some ideas, thoughts. You know, pretty much within a class of drugs, we really think of most of the drugs to be fairly interchangeable. You know, I'm going to use one ACE inhibitor or another based on really what's on formulary for a certain insurance company. You know, with ACE inhibitors, they're pretty much all on formulary for all insurance companies, so that's why lisinopril, the most commonly used one, is used all the time. There's some small differences in, you know, kinetics and dynamics and how long they work and those kind of things, but in terms of efficacy, we just consider it kind of a class effect. Losartan in the ARB class is the only one that has known uricosuric effects, meaning they actually help gout patients so they can decrease uric acid concentration. So that's always a fun pearl. Docs are getting more and more savvy about using losartan in those patients to help decrease the uric acid levels. You will find a lot of patients with hypertension have gout. And so if you're using an ARB, you should pick, losartan. That being said, it's kind of the weakest binding affinity to that angiotensin II receptor of all the ARBs, so you tend to have to use higher doses of it anyways to get the same effects, but it's a fun little pearl. We already talked about how loop diuretics typically aren't used with hypertension, so if you see them, there's likely another indication for the loop diuretic. We're talking about, when you're just talking about management and trying to decide, the electrolyte disturbances are a big part of that. ACE, ARB, diuretics, you're going to have to monitor kidney function and draw labs and monitor closely, whereas the beta blockers and calcium channel blockers are not affecting those. So, sometimes those are a great choice for somebody who's just not going to come in and get their labs drawn. So, and then keeping in mind in your patients with diabetes that sometimes beta blockers can mask those symptoms, the tachycardia, the tremor that can happen with low blood sugar. So, keeping that in mind. Watching out. So a lot of people are on ACE inhibitors and diuretics, or ARBs and diuretics. And then if they get added an NSAID on for some kind of pain, so non-steroidal, that is, dangerous. And those patients will kind of go into acute kidney failure and injury and, have a lot of management issues. So really educating the patients out there, because, they can get NSAIDs over the counter all the time. And so their doctor may not know that they're actually taking NSAIDs. So when we're talking about these medications in clinic with patients, we're really trying to educate them, hey, if you're on these, these are affecting your kidney function in a good way, hopefully, ultimately. But if you're having aches and pains, or you go to another doctor and they give you this class of medications called NSAIDs, that can be really dangerous. Not to say that you can't manage patients on that, and some patients do fine, but it is I guess in the pharmacy world, it's the triple death to your kidney. So I get questions. In fact, I just had a patient call me 2 days ago about grapefruit juice. So common one that you guys will hear. I mean, you really have to drink a lot of grapefruit juice for that drug interaction to be significant. So the majority of the time, I tell people, the lady I talked to this week, she ate a half a grapefruit 3 days a week. I'm like, that's not enough to worry about. She was worried about it with her statin drug, but amlodipine can also, at larger quantities of grapefruit juice, start to cause an interaction. They found that not combining the renin-angiotensin drugs, so don't give patients an ACE plus an ARB. I think that there are times where that still happens, and I don't necessarily know that it's the wrong thing, but there were some studies that showed that really combining those drugs together really didn't do much more except for add up cost. And then you have more risk of hyperkalemia and issues with the kidneys. So we tend not to use those combinations. Maybe in the nephrology clinic they still do it a little bit. No, don't do it. Okay. Yeah. So.
You know how much you add for blood pressure control? You add an ARB to an ACE? 1, 4.
Yeah.
Wow.
You're wasting your money.
Yeah.
You
So.
end up with a 15
Yeah.
So that's a big one.
Yeah. So I mean, I think back when ARBs first came out, everybody was trying this new class of medications in combination and trying to figure out whether this is the new great thing and whether we should combine them, and it just hasn't panned out to be useful, so we just don't do it anymore. Again, chlorthalidone being a lot more potent than hydrochlorothiazide. I think we've talked about that enough. And then, we talked through this whole thing about the comorbidity. So it's really about, do they have heart failure? Do they have gout? Thinking about the whole patient, not just their blood pressure, trying to choose the right medications that kind of fit their life. And then the old mantra about starting low and going slow in your elderly patients. They're going to be at most risk for those falls and problems and complications. And so kind of just starting low and going slow still applies to these drugs. Yeah.
About the NSAIDs and the ARBs. When you're talking NSAIDs, you're talking high dose or just over the counter?
Really, it can be any dose. Yeah, it can be over the counter stuff. Yeah, so just, educate them on what an NSAID is, give the names, ibuprofen, Motrin, Aleve, naproxen. You've got to say those common names out there. I mean, those are really the most common ones that you're going to hear, but, you can't say an NSAID because patients don't know what an NSAID is. So you really I just run through, the most commonly used ones and explain why it's important. But yeah, any doses, higher doses are worse, but certainly.
Just about management, so they start them on, and then so we should get them back into the clinic in about 2 weeks or so to check on their blood
Yeah,
pressure?
that's what we do. A week to 2. I mean, depending if you're starting ACE inhibitors and diuretics, you generally want their labs in a week. So a lot of times we'll just see them back for a quick blood pressure check in a week, see how they're doing, get them to get their blood work done, and then after that, Dr. Rueda also mentioned, that constant follow-up early on is important, and I completely agree. We'll talk about in a second kind of that lack of clinical inertia. You put them on a drug and you see them in 3 months. A lot of things happen in that 3 months. Most commonly, they have a side effect and they don't take their meds for 3 months. So, having them come back regularly at the beginning until you get them to goal is.
Yeah, 'cause I noticed they say follow up in 3 months. And it's like,
Yeah.
okay.
Yeah, and we found that didn't work. When I started in our clinic, we did a pilot project where I was, following up with them in a week and then again in 2 weeks, and we had an algorithm where we're just really constantly and then adding on a drug, and that was way more effective at getting people to goal. So just talk a little bit about improving adherence. This is a big one for me, not just for hypertension, but for everything. This was bubble packs that I confiscated from a patient's house, and as you can see, there are a lot of pills still in those bubble packs, and so, you got to get these patients to take their medications. We waste a lot of money on drugs when patients aren't taking them. So I often use bubble packs for folks, and CareOregon is nice enough to work with some of the people that do that and allow our patients to get it. It doesn't cost them any more money to have it done. So, what are the good things? Well, if patients are on stable chronic meds, but they just can't, piece it together and remember whether they took their meds, bubble packs are a great thing. They work pretty well. The other nice thing, they can be delivered to patients' homes. So those that can't get to the pharmacy regularly, they can get all their medications once a month in their bubble packs. And as long as things aren't changing, it's actually really convenient. The meds that are changing frequently and transitioning of care in and out of the hospital, or they're seeing their cardiologist and their diuretics are being changed frequently, that becomes really confusing for patients with bubble packs. And so, I mean, I do a lot of medication management where I've got those patients on bubble packs and I'm following up with them and they're bringing their packs and we're writing on the packs and we're changing their med lists and trying to make it work for them because the bubble packs really help them with adherence. But it does, I mean, it's a big source of errors in the community. And so you have to be really, really careful. And then I've had a few patients that, usually elderly patients or mentally ill patients that just can't figure out how to push the bubbles out well, cut them out, so, I often have had patients come back after they've been on the bubble packs and I find out, well, they're just pushing all their meds out and then putting them in a med box every month. It's like, okay, well, that's just a fancy packaging. So, trying to change that around. If they're going to put them in a med box, the same pharmacies that bubble pack will actually send them in pill bottles. So, if they're savvy enough to follow a med list and fill the pill box on their own, you can actually, it's kind of like mail order, you get your prescriptions, all of them mailed to you every 28 days and kind of keeps you on track. Don't have to go to the pharmacy, but they're in, pill bottles like you normally get at the pharmacy. So that's, the kind of thing. And, there is some wasteful packaging, I think changes in meds, things like that. There's a lot like that picture, of packaging, but, I I'd say, 75% of the time, bubble packs are great, so you can certainly think about it. Other kind of adherence things, here's a plug for Paul's MEDS chart. Using that MEDS chart with pill boxes to help educate your patients on their medications, having them have that filled out so that their doctors can go through that with them. I have one on the next page that's a little bigger. And that combination of a med list, pill chart, plus filling pill boxes sometimes is a really nice option. I've occasionally had patients who family really wants them to have a locked, so patients with dementia or whatever, who they can't seem to adhere to their meds. They have these timed locked pill dispensers. They're expensive, but a lot of times the family is willing to buy those for folks, because then at 8 o'clock timer goes off, reminds them to take their meds, pops open a drawer, their pills for that time comes out. You certainly have to have family members involved with that because they have to get filled and those kind of things, but occasionally that has been an option. Trying to use combination pills when it's possible. They keep coming up. There's literature out there about the poly pill, and Europe tends to kind of have most of that information. But a lot of our diuretics and ACE inhibitors are in combination. So just decreasing pill burden goes a long ways for a lot of these patients. And then syncing refills at the pharmacy, trying to get, because that's a big problem with adherence, is patients have 8 medications and they come due at different times during the month, and so they'll be taking them and then they forget to refill one because it's not the time to go to the pharmacy, and then the pharmacy puts it back, and so there's all kinds of problems with unsynced refills. This is where the Pop Intel database is really helpful, looking at kind of fill history, being able to tell when patients have filled their medications, and trying to work with the pharmacy then to sync up their refills is certainly an option. It's kind of maybe the thing to do even before you get to resorting to a mail or the bubble packing pharmacies to do that. So it's pharmacies, I found, are somewhat reluctant to do that, unfortunately. I think it's time consuming for them. They've got to have people work on it, but if you find the right pharmacy, they often will do that for you. MEDS chart, so using this for patients, having them, really educate them about why they're taking their medicine, what it's for, whether they like it or not, writing down their side effects, because a lot of times they'll go to the doctor and can't remember why they stopped taking a medication, and have them take this in with them. So if you're out there, definitely utilize this with patients. It's not, it tends to be harder to use in the clinic, just because they're coming in. You're typically not going through this whole thing and filling it out in the clinic. It's something that y'all should be giving patients in the community, having them fill out, work through with them, and take it to their doctor to follow up. And then we talked a lot about this, but just thinking about, okay, a patient isn't responding to their medications, what are the reasons? So, these are the things that I'm going through. Well, non-adherence to therapy is the biggest one. Cost of medications, it's not really that much of an issue in our CareOregon Medicaid patients, because they don't really have to pay for their medications, and they're all generic, so it's relatively inexpensive, but occasionally that will become an issue. Sometimes patients just don't understand the instructions, and so I have patients all the time, well, I take it twice a day because that's what the label says, and then I read the label and it says once a day, and so, just trying to make sure that the health literacy is at the level that, a patient can read a label and make sense of it is really important. If they didn't get educated on these drugs, there's a good chance that they may stop it. They get a side effect, and, if they weren't told that they were going to have a side effect, they just stop it because they don't like it. So just educating those folks up front, or out there as they're taking these. If the patient wasn't involved in kind of coming up with that decision, they're going to have less buy-in to taking a medication longer term. Of course, side effects and you know, dementia or memory issues can definitely lead to that. And then inconvenient dosing. You know, yes, we try to get people on once-a-day medications because the adherence rates really drop off with, you know, once a day to twice a day to 3 times a day. And so, you know, nobody takes medicines 3 times a day. I mean, virtually nobody. Bubble packs help. I really have seen those patients on hydralazine, you know, that are on TID, QID, you know, hydralazine and clonidine that are on bubble packs, and it certainly does help. So you can get those folks to do it, but it's not convenient. It's not what we prefer to do in the majority of folks. So try to get them down to twice daily therapy at the most. You know, sometimes doses are just too low. You know, like you said, lisinopril 10 milligrams is probably not enough for most patients. So making sure that doses are getting changed regularly. You know, maybe there's the 2 drugs from one class. You know, I've seen patients, you know, that have multiple providers, and one puts them on one ACE inhibitor, and then another one puts them on another ACE inhibitor, and then they come in. So, you know, it's just really important to make sure that the combinations are that they make sense. Drug interactions, we talked about NSAIDs a bit, you know, other things that cause, you know, blood pressure issues and are drug related, you know, kind of goes down through venlafaxine can increase blood pressure a bit. Pseudoephedrine, as we know, can. Nasal decongestants, even licorice, black licorice containing products, of course, cocaine and methamphetamines will certainly do it. Cyclosporin and EPO, things that we don't see in primary care a lot, but certainly are out there. You know, those other conditions, you know, increasing obesity, you know, alcohol intake. I've had patients who either were known drinkers or were unknown drinkers who we were giving 2, 3, 4 medications to control their blood pressure, and come to find out, you know, they're drinking excessively. Once that was stopped, their blood pressure bottomed out after they continued taking their 4 medicines. So, you know, it's really important to get that alcohol history. Chronic pain, sleep apnea, and just keeping in mind that sometimes those patients do come in, that white coat hypertension, you know, they're always in the office, their blood pressure is always high. They may or may not feel nervous in the office, but if their blood pressure is high, you know, this is where that home blood pressure monitoring really plays a role. Volume overload, I think we kind of beat that one too, you know, in those patients who just, you know, they aren't on enough diuretics to really pull off the amount of sodium needed. The improper blood pressure measurements. I've had a lot of patients come and their blood pressure's been high at various times in the clinic, and, you know, and they get treated based on the blood pressure, and a lot of times, you know, the patient was sitting, you know, in a chair and their arm was up here, or their arm was down here, or they were laying down, and those things weren't taken into consideration when they made a therapeutic decision to treat somebody. And so keeping that in mind is really important. And then just lack of clinical inertia. You know, I think as primary care physicians out there, they get pretty bogged down with everything that they have to do. And so when the patient comes in and their blood pressure's, you know, 148 over 92, oh, looks pretty good. We'll deal with that next time. And the next time rolls around, oh, that looks pretty good. We'll deal with that next time because we have this to deal with. And, you know, that lack of clinical inertia doesn't get that patient to goal. And so kind of having those organized, you know, programs that kind of are focusing on hypertension is really important. All right, so we're going to quickly go over this case, and then we're going to turn it over to Julia to talk about the most important things, which are diet and lifestyle. So 61-year-old African-American patient comes. Has been in the ED several times for work-related back pain. It was noted that his blood pressure was high in the ED, so he reports that his blood pressure is at home, generally in the 150s over 90s. Past history, significant for high cholesterol, some low back pain. Family history of diabetes, but personally, he's, you know, just at increased risk or pre-diabetic with A1C of 5.8. He had a normal potassium at 3.6, normal low. And then otherwise his electrolytes looked good and he had no proteinuria. So Julia already educated him all about the DASH diet and talked to him about physical activity, but you know, as you hear, you know, most of them they have physical jobs, so they don't tend to do much after that. Pretty common, but he does his best to, you know, keep his sodium down, eat his vegetables, and so he is on aspirin, a statin, a little PRN, ibuprofen. So you are out there, you find out about this guy, you give him a call, you know, see your blood pressure's high, you really should come in, get your blood pressure checked so we can follow up on this. So he comes in, his blood pressure is 156/92, heart rate 84. So, you know, what medications would be most appropriate for this gentleman? What are those factors that we talked about here that are going to help you make that choice? What's that?
So either an ARB or a Synagro or some other option.
So an ACE, an ARB, anybody?
Calcium channel blocker.
Calcium channel blocker. Anybody for diuretics? Diuretics, all right. So, you know, I don't think that any of those are necessarily the wrong answer for this gentleman. Why did you say calcium channel blocker?
It's more effective in African Americans.
Okay, so African Americans, right, are going to respond less to ACE inhibitors and ARBs, so that's a good choice. Diuretics are a good choice in an African American. Not to say that an ACE inhibitor won't work, but it's less likely to work as a first-line agent. So all of those things come into play when you're trying to figure out whether or not we're going to pick that first-line agent. So according to the guidelines, you know, those are all options. In an African American, if you remember the algorithm, they really recommend amlodipine and diuretics as first line. So we probably pick that for this gentleman. So, all right. Questions now, Paul? Questions now? Okay. I don't know where we're at time-wise, but yeah.
Have you heard of insurances covering like a 30-day pill organizer?
Covering the like pill boxes for 30 days?
The patient wanted to like purchase a 30 days.
I have not ran across, like, a lot of times this is in Medicare folks, the older people that, you know, want that, and I haven't found that Medicare's paid for that before. I don't know about CareOregon and Medicaid folks. Do any CareOregon folks know? No, like a longer day, like the pill dispensers and longer organizers. I don't,
Not as a rule.
yeah, maybe you could get exceptions or something if there's a specific case or something that came up, but generally speaking, yeah, not really. You know, most of the pill boxes out there are weekly, you know, 4 times a day or 2 times a day or 1 time a day or whatever. A lot of times I will fill a pill box that's 4 times a day and I'll change it into a 2-week box. So I'll take AM, PM, AM, PM and take all 4 rows and make it into 2 weeks for patients. So I've done that, but I haven't found a way to get somebody 4 weeks of pills all at once other than bubble packs. Yes.
Chris, what's your strategy for switching, timing-wise, for switching someone from like metoprolol to carvedilol?
Timing-wise being, you know, like
So when do you stop
stop one and
the dose conversion? Because I think that
yeah.
there's not really very good guidance.
Yeah, there's not. So we just kind of make it up. I mean, really, I mean, most of the time it's not critical. So, you know, you've got room to move with their blood pressure going one way or the other way. So there are certainly the dose conversions between metoprolol and carvedilol doses, but just when to stop one and the other. You know, you're generally, if they're on long-acting metoprolol, you know, stopping that in 24 hours and getting them started. But there's not great. Yeah.
Confirm the diagnosis of hypertension. I always thought it was 2 to 3 greater than 150. Is it now 140 or?
Yeah. Yeah.
So it's 140?
Yeah. Hypertension definition. Yep.
Let's give Chris a big round of applause, guys.
Thank you.